Getting rough between the government and the doctors in this upcoming doctor strike. The Health Secretary is now directly accusing doctors preparing to take the strike action of playing games with people's lives.
So how can we get people to work for the NHS if we're not treating them fairly?
6 years in medical school, 8 years on the front line, a 26% real terms pay cut, and a system that keeps demanding more with less. That is the price the NHS is now forcing its frontline to pay. The NHS employs around 1.5 million people across England. Yet in just 1 week, more than 40,000 frontline staff walked away. In just 24 hours, 56 areas were forced to reduce their emergency response level. Thousands of life or death calls were rerouted as response times began to slip. But the most dangerous pressure cannot be seen. It sits inside budget decisions, inside emergency spending expanded for welfare and accommodation, directed toward those who have only just arrived in this country, while core services are told to tighten further. No announcement, no warning. This is no longer a signal. This is the moment Britain's emergency system begins to bend. From here on, every decision slows and the cost is no longer confined to paper. The NHS is no longer defined by shortages alone. It is being constrained by the way the system is now governed. Frontline decisions are no longer purely clinical. They are filtered through policy frameworks imposed from the centre.
We are turning that around, getting the waiting list down, the ambulance times are coming down. It will take time to turn this around.
Emergency care still exists, but the authority to act has narrowed. In some trusts, urgent cases now pass 2 to 3 additional approval steps before action is taken, not because doctors hesitate, but because every decision must survive review. What failed was not staffing, it was momentum. Doctors and paramedics now carry 2 risks: medical failure and professional exposure. A decision made in seconds can be examined for months. As compliance is prioritised, emergency waiting times in parts of the system have stretched beyond twice their original targets. When speed becomes a liability, hesitation is no longer optional. It becomes the system's default setting. Industrial action does not come from anger. It comes when a workforce loses the right to act within its own profession. That frustration finally spilled out of the hospitals. Tens of thousands of doctors and NHS staff walked off shifts and gathered outside Whitehall in London, standing face to face with the centre of political power. At the same time, in Birmingham, Manchester and Liverpool, city squares and NHS trust entrances were filled. This was no longer a series of isolated protests. It became the largest coordinated healthcare demonstration in years, unfolding across England. The placards were not just about pay. They spoke of unsafe hours, staff shortages and exhaustion baked into the system. One message kept repeating: the front line is being pushed beyond its limits. And yet the government continued to call for stability, resilience and efficiency. The real conflict was not on the streets, but in priorities. While doctors were told to do more with less, emergency funding streams were quietly redirected toward humanitarian response, accommodation and welfare plans for those who had only just arrived in the country, often after dangerous sea crossings. No one said compassion was wrong, but the front line asked a different question. Why is their sacrifice always treated as automatic? As ministers focused on managing headlines, NHS managers were instructed to freeze recruitment, delay training and reshuffle budgets. Junior doctors saw their futures blocked. Senior staff saw decades of experience drained, and trust, the invisible force holding the NHS together, began to fracture. This was no longer an industrial dispute. From here on, every choice became political, and this time the cost would not stay on paper. What pushed this to breaking point was not ideology, it was consequence. Hospitals were already running below safe capacity when the protests erupted. Rotas were patched hour by hour. Wards remained open on paper, but not in practice. Beds existed, staff did not, patients felt it first, appointments cancelled with no alternative dates, operations postponed again, Ambulances waiting outside hospitals because there was nowhere to hand over. Families told to be patient, then told to wait longer still. This was not caused by one strike. It was the result of a system forced to ration care quietly. Doctors watched as emergency services were stretched thinner, while funding decisions moved faster elsewhere. Temporary accommodation expanded, support frameworks multiplied, new commitments were announced with urgency, while NHS staff were told to absorb pressure, delay care and manage expectations. No votes, no clear explanation, just a shift in priorities. For many on the front line, that was the final fracture. They were not being asked to save lives under pressure, they always had. They were being asked to carry the political cost of decisions made far from hospital corridors. And this is where the danger lies when a government transfers risk downward, from policy desks to doctors, from spreadsheets to patients. The system does not fail loudly, it fails quietly. One delayed ambulance, one cancelled operation, one family waiting too long. The NHS was built to protect the public when everything else stops. But when it is governed to protect politics first, the public is left exposed. That is not a warning. It is the reality now unfolding. As the protests grew, the official response followed a familiar pattern. Statements were issued, assurances were repeated. The language was careful, technical, and designed to calm rather than confront. Ministers insisted contingency plans were in place. NHS England spoke of resilience, ongoing monitoring, and local flexibility. Pay discussions were described as complex, workforce pressure was framed as seasonal. The public was told patient safety remained the top priority. What stood out was not what was said, but how it was said. There was no urgency in tone, no acknowledgement of scale, no admission that the system was operating closer to the edge than publicly stated. Press briefings focused on process rather than consequence. Review panels, ongoing talks, and future reforms were emphasised, while the immediate strain inside hospitals was treated as something to be managed, not faced. A gap widened between what was being experienced on the ground and what was being presented to the country. For those watching closely, it became clear that the government was responding not to the crisis itself, but to how the crisis appeared. More revealing than the statements were the silences. There was no clear explanation of how emergency thresholds had tightened so sharply, no transparent account of how short-term funding priorities were being shifted, no direct answer to who ultimately carries responsibility when care is delayed, but policy has been followed. Key questions were left unanswered. Why is clinical autonomy narrowing while governance expands? Why are staffing bottlenecks described as temporary when they persist year after year? Why are emergency pressures framed as exceptional when they are becoming routine? Inside the NHS, staff describe a system that rewards caution and penalises deviation. Outside, leaders avoid addressing how that culture was created. Responsibility dissolves upward through layers of governance. When outcomes worsen, failure becomes systemic, delay becomes unavoidable, risk is acknowledged only after it has landed on patients. For frontline workers, this silence is not neutral, it shifts the burden downward. Clinicians are left to explain delays they did not design. Managers defend decisions they did not authorise. Over time, silence itself becomes policy. This is where Britain now stands. Not at the edge of sudden collapse, but at the point where expectations are quietly reset. Longer waits, less certainty, more explanations after the fact. The NHS was built on a simple promise: when help is urgently needed, the system moves first and explains later. That promise is now being rewritten without debate. The question is no longer whether doctors are justified in protesting. That moment has passed. The question is whether a system can continue to function when responsibility flows downward but authority does not, when risk is absorbed by those closest to patients while decisions remain insulated above. For families watching this unfold, the issue is not ideology or policy design, it is proximity. How far away is the nearest functioning emergency service? How many steps now sit between urgency and action? And who decides when delay becomes acceptable? These are not questions for doctors alone, they are questions for the country. Because once a health system lowers its standards quietly, restoring them is never quick. And by the time the consequences are undeniable, the space to act has already narrowed. Britain is approaching that moment now, not with sirens, but with silence.